Hello, everyone. I'm Sheila Myatra, Professor of Anesthesia and Intensive Care, working at the Tata Memorial Hospital in Mumbai, India. At the outset, I'd like to congratulate and also thank the Safe Airways Society, especially Nicholas Crimes and Matthew Humar, for giving me the opportunity to take this lecture. I will be speaking on extubation options for the at-risk airway. I will restrict my talk to only at-risk extubations and not the normal extubations that we perform in normal airways. I like to compare tracheal intubation and tracheal extubation to various phases of flying a plane. I look at tracheal intubation like the takeoff, and just like the takeoff is a very critical period of the flight, and there are various safety considerations, and you want to have a smooth takeoff. I think having a smooth landing is equally important, and to me, this is like having a safe extubation. So I don't like to call it a difficult extubation because extubation is never difficult. What is extubation? It's about removing the tube. So how does that become difficult? It's just about pulling out the tube. What we have to focus on is what is extubation failure. So let's try to understand what we mean by extubation and extubation failure. So extubation is defined as a purposeful removal of a tracheal tube and the transition from a well-established airway to normal natural airways. And when we say extubation failure, this is the inability of a patient to maintain a patent airway with effective spontaneous ventilation after the purposeful removal of a previously placed endotracheal tube within 24 to 72 hours. Now, if you look at extubation of the difficult airway, it's actually quite an important procedure, but it's often very neglected. And this is reflected by the high incidence of complications. Now, you might say these complications are less than during tracheal intubation, but even though the incidence is lower, this leads to an overall increased mortality. If you look at the national audit project that was performed in the UK almost 10 years ago, and the report shows and this looked at intubation, complications related to tracheal intubation, both inside and outside the operating room, you will see that 30% of all the adverse events were related to tracheal extubation, mortality of 5%, and 13% for severe outcomes. Even the ASA close claim shows that death and severe brain damage were most often associated with extubation. So what really makes extubation hazardous? So it could be related to the pre-existing airway difficulties that were present, could have been difficult mask ventilation, difficult tracheal intubation, or there could be perioperative airway deterioration. During surgery, there could be some nerve injury, the airway reflexes may get compromised, there may be airway injury or some obstruction, or even surgical excision. For example, if a commando surgery is performed, you might have a part of the mandible, extensive resections, especially during cancer surgeries, or you might have restricted access post surgery. For example, if there's some dental wiring done. There could be associated medical conditions. Now, these patients, for example, a patient with obstructive sleep apnea preoperatively is an at-risk extubation. There could be various reasons for depletion of oxygen stores during extubation. So there could be secretions, there could be atelectasis, there could be various pharmacological and physiological factors. For example, residual effects of neuromuscular blockade or opioids or even anesthetic agents. And most importantly, some human factor considerations. Now, if you look at tracheal intubation, you have a lot of people around, a lot of help when there's a difficult intubation. But during tracheal extubation, you have sometimes just the junior most anaesthetist performing the extubation. You may not have many people around. You will have a lot of the airway equipment has been packed and put away. And this is actually a very important phase of airway management, but is quite neglected. And these human factor considerations have to be taken account if you want to reduce the extubation-related complications. Now, there are various extubation strategies for at-risk extubations. You could perform a deep extubation, remifentanil extubation. You could use a Bailey's maneuver if you want to extubate someone in deeper planes, Or you could use an airway exchange catheter in those patients which are considered to be a difficult intubation or extubation using a flexible bronchoscope. And I'll speak to you about some of these interventions. First, let's try to understand what we mean by a Bailey's maneuver. Now, a Bailey's maneuver is an advanced airway maneuver, and this needs to be learned. Essentially, what you're doing, you're exchanging an endotracheal tube with a supraglottic airway device. And why do we do this? Because we do this in patients in whom we want a very smooth extubation, those who are high-risk patients with cardiac conditions or brain injured patients in whom we don't want the patient to be coughing and bucking on the endotracheal tube. So we replace the endotracheal tube with a supraglottic airway device, keep the patient spontaneously breathing, and extubate, remove the supraglottic airway device in slightly deeper planes. And there are various ways in which you could do it. And one is you could slide, as you can see in this picture, you could slide the supraglottic airway device behind the endotracheal tube, and then you could gently remove the, deflate the cuff of the endotracheal tube, remove the tube while pushing the supraglottic airway in its place. Another way of doing this is just remove the endotracheal tube in a deeper plane and replace it with a supraglottic airway device. Or if this patient also had a difficult intubation, you could consider removing the endotracheal tube over an airway exchange catheter. So remove the tube and then put a supraglottic airway device over the airway exchange catheter and have it in place. Now, very importantly, before extubating any patient, you should ask yourself these two questions. And I always do this. The first question is there a risk of extubation failure? So we're not talking about the routine extubations in normal airways. Was this a difficult intubation? Has anything happened during surgery that can make this an at-risk intubation? Is this a high-risk patient? So there are various factors that increase the risk of extubation failure. And the second, more important question is, will reintubation be difficult? Now, if the reintubation, this was already a difficult intubation or something has happened in the perioperative period that is going to make your reintubation difficult, and the answer to both these questions is yes, you have to be extremely cautious. I would not extubate such a patient without using an airway exchange catheter or a bronchoscope. I'll talk a bit about the airway exchange catheter. Now, the airway exchange catheter is a very useful tool we have in our armamentarium. However, sadly, it's very underutilized. And it's used for tube exchange. And you have not only the plain airway exchange catheters that are often more than double the length of the tube, but you also have staged extubation sets now with guide wires. So they're more comfortable for the patient. So you could put in the airway exchange catheter, and then you could deflate the cuff of the tube and remove the endotracheal tube, and you could pass a guide wire through this, and you could just leave the guide wire in place rather than leave this catheter and make it uncomfortable for the patient. And this is especially very helpful in those patients in whom you feel reintubation may be difficult, because just in case you extubate the patient and you feel that he's not going to tolerate this extubation, he has some airway collapse or he's going into stridor, and you want to reintubate this patient and he also had a difficult airway, it's very easy to just slide the tube back over the airway exchange catheter. And the use of airway exchange catheter does increase the first attempt of reintubation chances, to a much higher, as compared to when you don't use it. 87% with an airway exchange catheter compared to 14% without an airway exchange catheter. Just a word of caution with the use of airway exchange catheter. You need to be very careful when you use these devices, because these aren't without complications. Very enthusiastically, people slide these airway exchange catheters quite inside, and they go endobronchial. Be very careful about this. Do not insert the airway catheter more than the marking of the tracheal tube at the level of the incisor. You don't want it going endobronchial. And the other very important point to keep in mind that these are hollow. A lot of people give oxygen and jet ventilation to this. Do not do this. This can be very dangerous. There have been various case reports where there have been pneumothoraces and other life-threatening complications. You should provide, once you remove the tube and you have an airway exchange catheter in place, you could provide supplement oxygen using a face mask rather than use the airway exchange catheter. And you could keep these airway exchange catheters in place up to 4 to 6 hours, following which, if there is no problem, and you can just remove the airway exchange catheter. Usually after about an hour or so, you know whether the patient will need a reintubation or not, and you could consider safely extubating the patient. Another word of caution is, once you've extubated the patient and you put in this airway exchange catheter, make sure you secure it and fix it well. Otherwise, you may just have the patient coughing out the tube. Now, there are various guidelines for the management of tracheal extubation, and we have very nice, elegant guidelines that were published in 2012 from the Difficult Airway Society. So DAS has given guidelines for, for basic extubation, and also for the low risk extubation, and another algorithm for the at-risk extubation. In 2016, the All India Difficult Airway Association published guidelines for extubation for the management of anticipated difficult airway. And I would like to focus on these guidelines because they give a very nice stepwise approach to how you could, extubate the various at-risk patients. And I'm very proud to be a member of this excellent team that put these guidelines together. And I must say that a lot of thought were given to the various at-risk extubations. Again, I'd like to put you through the algorithm, but before I start, I would like to say that we're not dealing with the normal extubations in normal airway patients. We are talking about the at-risk extubation. So this has, the IDA algorithm has three limbs, and I will cover each of these limbs. And these actually depend on the various risks that you're talking about during extubation. So one is for extubation of a normal airway, but an at-risk patient. And then we have, the 4Ds. That is a patient who had a difficult mass ventilation or intubation or some delayed recovery, or because of some pre-existing disease. And then we have the 3S's, and these are related mostly to surgical factors, like a surgery causing airway compromise, or if there's some airway edema, or there's suspected airway collapse post-surgery. So I'll cover each of these limbs. Now let's come to the first limb, where the patient has a normal airway. This is not a difficult airway, but the patient has some condition, some medical condition, which requires suppression of the hemodynamic reflexes during extubation. So you could consider either doing a awake extubation, but you don't want tachycardia, hypertension. So you could use various pharmacological agents to suppress these reflexes, like beta blockers, dexmedetomidine. You could do this, or you could do a deep extubation where you could do exchange the tube with the subglottic airway device, like I've shown you the Bailey's maneuver. And then you could remove the subglottic airway device when the patient is relatively awake. But remember to give oxygen throughout the steps of this procedure. Now, coming to the second limb of the extubation algorithm. Now, these are the 4Ds. Now, the at-risk patients which have had a difficult mass ventilation, or the patients have a difficult intubation, or he's had some delayed recovery, or there's some pre-existing condition. For example, a very obese condition, a patient, or someone with obstructive sleep apnea, or some condition like this that's already been there. And remember, whenever you are doing these extubation of these at-risk patients, the first step is keep the difficult airway cart ready, because you have to be ready to re-intubation this patient if required. Now, if you have any of these 4Ds, you should try to extubate the patient in awake condition when he's following verbal commands and he meets the criteria for extubation. And recruitment of the lung is desired if not contraindicated, and give oxygen supplementation throughout. You could consider extubating them over an airway exchange catheter, as I've shown you, or using a flexible bronchoscope. And then, of course, when you feel there's no need to reintubate this patient, you could consider removing the airway exchange catheter, but remember oxygen supplementation throughout. And coming to the third limb, and this is more related to surgical factors. When you have a surgery that's compromised, caused, there's some wide excision, or something that could be compromised, nerve injury, or there is some edema, or some condition in which there is airway obstruction. Now, if there is very wide excision, as you see in cancer patients, where there's a mandibulectomy, or they've gone very wide with the excision, you may consider an upfront tracheostomy for this patient. However, in other cases, especially when you're suspecting, say, laryngeal edema, you can consider doing the leak test. Now, a leak test has a lot of false positive and negative results, but it gives you some assessment of the airway, and it can help guide you. So it may be performed. And if a leak is present, then you can consider safely extubating this patient over an airway exchange catheter or a bronchoscope. Now, if the leak is absent, or a patient is or is equivocal, then you could consider a delayed extubation for this patient. If you are suspecting any airway obstruction or stridor or something to occur post surgery, you can consider delayed extubation. What we mean by a delayed extubation is you keep the tube in place and you can consider extubating them at a later phase after probably treating the edema. Now, once the whatever reversible condition has been handled, and you still have the patient going into stridor, or you have the patient not being able to maintain a patent airway, you might actually have to consider doing a tracheostomy for this patient. So this is how the algorithm looks at, very simple, addressing every type of at-risk extubation, even a normal extubation in a patient who is at risk, or various factors related to tracheal intubation that make the patient at risk, or various surgical factors, including edema, that may make the patient at risk. And I'd like to demonstrate this by showing you a case. And this is a 55-year-old lady, and she's come from the interiors in a small town where she has this big tracheal swelling, which has progressively increased over the last 6 years. She's not bothered much about it. She was very scared to go to a doctor, but now she's going into, when she lies supine, she goes into stridor. She's unable to lie completely flat. So she's presented to the hospital with such a large thyroid mass. Fortunately, you can get under the settling swelling. There's no retrosternal extension. It's all in the neck. And if you look at the CT scan, you can see that you can just see the trachea here, and there is a significant compression and deviation of this trachea. I won't go into how we intubated this patient, but I will like to ask what would be the extubation strategy. Now, obviously, this thyroid mass has been removed, and this is now, the question is whether you have to perform an extubation, or you'd like to do a delayed extubation following the surgical excision. Now, neuromonitoring was performed for this intra-op. Neuromonitoring was performed, and the surgeons did not think that there was any nerve injury. However, the surgeons did give me a history that the tracheal rings were very soft and very supple, and they were suspecting tracheomalacia. This was also a very long-standing thyroid, so these patients are at a risk for tracheomalacia. And considering this risk of having dynamic airway collapse, we deferred doing a extubation on table, and we did a delayed extubation. We extubated this patient after 48 hours. And the reason for extubating more delayed, you don't have to give mechanical ventilation, you just have to keep the tube in place. And the reason for doing this is also because you can have some fibrosis setting in, which can stabilize the trachea and avoid this dynamic collapse. Now, the way to extubate such patients, it's often good, rather than using an airway exchange catheter, to use a flexible bronchoscope. So what one could do is put in the flexible bronchoscope through the tube and visualize the trachea distal to the tube, and then deflate the cuff of the endotracheal tube. And as you're withdrawing the endotracheal tube, you can visualize the trachea distal to the tube. If you see any dynamic airway collapse, you can just slide back the tube inside. And if you see that there is no dynamic airway collapse, you can safely extubate the patient over the bronchoscope. So this is one area where a bronchoscope definitely scores above the airway exchange catheter, because not only do you have a guide to reintubate the patient, but you can also visualize the trachea to look for any dynamic airway collapse. And this is the way we handled this extubation. And after 48 hours, we saw that there was no dynamic airway collapse, and she had a very safe extubation. So I leave you here again with the guideline, which gives you a very systematic approach to handle the extubations of the at-risk airway. Like I mentioned, in this particular case, we could have done an upfront tracheostomy, but a tracheostomy was avoided and we planned a delayed extubation. Post-extubation care is very important, especially if you've had a reintubation or a very, difficult extubation. You've had some problems during extubation. Make sure you treat airway edema if it is present, because the airway can deteriorate and may need a reintubation. Monitor for complications and keep the patient in a controlled environment. And this is very important because the airway might further deteriorate. If you've had any complications during extubation, make sure you document it, so this is known to other, people, especially when she goes for another anesthetic. And remember to counsel the patient and the family if feasible. I'll end, and this is my take-home message. And the most important point I want to make in this talk is that unlike intubation, extubation is always elective. So don't be in a hurry to perform extubation. If you don't have the required equipment or you don't have the expertise, delay the extubation. Call for help. Call people who are, call for whatever equipment you need. You don't have to urgently extubate like you may need to intubate a patient. So remember, extubation is always elective. We shouldn't fail this. We shouldn't have complications during extubation, unlike during tracheal intubation, where sometimes we may need to do an emergent tracheal intubation and we don't have many choices. Extubation failure has grave implications with high rates of death and brain damage than during other phases of anesthesia. So we have to be extremely careful and aware of this. Identify patients at risk for extubation, including the risk for extubation. Reintubation, like I mentioned, ask yourself the two questions. Is this an at-risk extubation? And the second question, is reintubation going to be difficult? And if the answer to both is yes, don't take this lightly and extubate the patient over a tube exchanger or a bronchoscope. Now, a pre-established extubation plan and for a possible need for reintubation should be discussed with this team. This is extremely important. You have time. You don't have to urgently pull out the tube, and you can do this with your members of the team, and use an airway exchange catheter whenever you're in doubt about whether the reintubation is going to be difficult or not. It's better to use an airway exchange catheter and use it appropriately. And remember, most importantly, give oxygenation throughout the procedure. Thank you very much for your attention.